Alright guys, so last time we were done with up to question number 20. So since this form that I have for NBME 18 isn't exactly broken up into blocks, I'm just going to try to do up to 20 questions per block or per video, because what I've been doing is I've actually been trying to teach more during the videos as well. So every time I do a question, like the last question we did in our last video, for this one right here with the VQ mismatch stuff, I also go into first aid and teach a lot about it, so that there's more than just the answer there. So it does take up a little bit of time, and I don't want to go over an hour and a half per explanation video. So right now, the first thing I want to do is tackle one of the questions we had to skip last time. So question number 2 over here. Excuse me. Question number 2 over here I had to skip because I had a little error in the explanation. I had the correct answer in the last video too, but I couldn't break down the explanation because I mismatched the relationships that I was mentioning in the explanation. So this question says, a 4-year-old boy, person 3-2 in the pedigree, right, so that's this one right here, has had a clumsy gait for the past year. Examination shows calf hypertrophy and proximal muscle weakness. Serum creatine kinase activity is increased, and muscle biopsy shows a loss of muscle tissue, regenerating muscle fibers, and fibrosis. A maternal uncle, this guy right here, had similar findings and died at age 15, which is why he's crossed off. The patient's 20-year-old sister, which is this one right here, is pregnant, and ultrasonography identifies a male fetus, which is very significant because this entire question is about either Duchenne or Becker, and both of those are X-linked recessive. So this mother is about to have a child, right? And they're asking which of the following is the probability that this male fetus has inherited the disorder. So here the answer was C, 1/4, and this is actually supposed to be a very easy question. The reason oftentimes questions like this become difficult is because of your inexperience with genetics questions. Anytime you have a question like this, there's a very systematic way of solving it, but if you have a lot of experience solving questions like this, you would know immediately it's 1/4. So what's happening here? The mother, 3-1, this one right here, has a 50% chance of being a carrier because she's a normal female, so she's definitely not affected, but she has an affected sibling and a normal father, right? So basically what's happening here is we know that this guy, her young 4-year-old brother, this guy has the disease because he got an infected or affected X chromosome from the mother, right? Because with X-linked stuff, as a son, you do not get your X chromosome from your father. You get a Y chromosome from the father and an X chromosome from the mother. So this mom definitely has one X. She's a carrier. She's for sure a carrier, right? 2-1 is definitely a carrier. She gave the affected X chromosome to that son. She might have given the same affected X chromosome to this daughter as well. So this woman over here, the sister, has a 50% chance of being a carrier. The man she marries is most likely not a man with muscular dystrophy, because why would she do that to herself? But regardless of whether he has an affected X or not, he will not pass it to his son, right? Because this woman is about to have a male fetus. So even though we don't know who she's marrying, right, the status of the person she's marrying, it's okay because he's not going to contribute the X chromosome to the son this woman is about to have. So this question really just came down to 2 independent events. One, the chance that the mother is a carrier, which we just established is 50%, and then the chance that the kid will inherit that affected X chromosome. So basically the chance that this woman herself is a carrier, and then the chance that she will give that affected X chromosome to her son too, right? Or she'll give the normal X chromosome to the son. So it's two 50% chances. You multiply them into each other, 1/4, and you're done. You wouldn't really need to think all of this in your mind during the test because you're going to have experience solving questions like that like we did right now, right? So things like this can become difficult though, because if you don't have the experience but you know the routine way of solving such a question, things that might confuse you are the fact that you don't know who she's marrying, right? But again, unnecessary. You might not actually remember that Duchenne or Becker are X-linked, but both of those are high yield topics, so you definitely want to make sure you remember that. The third disease that was muscular related on this one is actually a not a trisomy. It's a repeat one. Let me show it to you guys. So where is it? Biochemistry, genetics. Right here, muscular dystrophies. So there's 3 diseases here. There's the Duchenne right here, the first one, where age of onset is before 5 years. Our question, they probably had Becker because they're mentioning ages that are much higher than 5. So the Becker is the second one right here, X-linked disorder. They're both X-linked recessive. And then the last one here is myotonic type 1, which is a trinucleotide repeat, right? CTG, which you always remember as cataracts, 2P because of the early balding in men, and gonadal atrophy. So those are the 3 things. But our question was most likely about a patient with Becker, and Duchenne is a lot worse. Duchenne is the really, really problematic one that has myonecrosis and whatnot. So definitely make sure you want to know your diseases in biochemistry genetics, every one of them that they mention here, and then how to solve it in terms of a genetics question. So that was the one we couldn't explain yesterday because I made a mistake. In my explanation, I was talking about these 2 as being the ones getting married, which is wrong. So the explanation that I had last time was just not worded correctly, that's all. Alright, so now we're up to number 21. Let's take a look. A 32-year-old woman undergoes an operation after the diagnosis of hyperparathyroidism is made. During the operation, 3 parathyroid glands are found on the posterior surface of the thyroid gland, but one does not appear in its normal superior location on the right side. Which of the following embryologic events is the most likely cause of the findings in this patient? So this is just about the embryological development of your parathyroid glands. You have to remember that the 3rd pouch structures end up below the 4th pouch structures. They kind of switch places with each other. So the 3rd pouch is the one that gives you your inferior parathyroids from the dorsal wings, while the 4th pouch gives you the superior parathyroids from its dorsal wings. The ventral wings of the 3rd one give you the thymus, and the ventral wings of the 4th one give you the C cells of the thyroid. Right? Those are the significant things for this question. So the answer here was just A, abnormal migration of endoderm from the 4th pharyngeal pouch, right? And you picked the 4th one because this patient was missing the superior location one, right? And the 4th one goes above the 3rd one. So if you look at that in page 676, so let's take a look. So they have it on page 607 of first aid. They don't have a picture for it, but they do explain the 3rd pouch and the 4th pouch. And you would think, coming top down, that the 3rd pouch would give you the superior parathyroids, but they don't. The 4th one goes above it, and you can kind of catch that in this picture I have here, where, let's see, so you have your pharyngeal pouches here, right? You have your 3rd one, your 4th one. What's going to happen is there's going to be a weird invagination that occurs here, right? And I wrote it here. In this image to the right, you can see the 3rd pouch has yellow and red parts for the dorsal and ventral wings. Right? That's the yellow part on the top, the red part on the bottom. The same is true for the 4th pouch, which has a yellow and blue part, right? The yellow and the blue. The yellow dorsal parts give the parathyroids, and it's important to remember them. And those yellow parts are the ones that are going to kind of switch places, and one is going to go over the other. The 4th is going to go above the 3rd. So the 4th one is the one that gives you your superior parathyroid glands, and the 3rd one gives you your inferior ones. And then you can see the thymus and the parafollicular C cells, all of which are topics that are pretty high yield. A 25-year-old woman comes to a physician for counseling prior to conception. She has seizure disorder, well controlled with valproate. She asked the physician if her fetus would be at risk of her drug therapy. The fetus would be at greatest risk for a drug-related adverse effect at which of the following stages of pregnancy? Now, valproic acid is a teratogen. Most actually anti-epileptic medications are teratogenic, or just either they're teratogenic or they're not safe for you to take when you're pregnant. Not simply because of teratogenic events, but other stuff. So this question, they're not even asking you if it's teratogenic. They just want to know. They just want to know, when the teratogenic symptoms would pop up. And you should remember that all teratogenic medications are most dangerous when the fetus is developing most rapidly, and that actually occurs between the 3rd to 8 weeks, right? Those are the weeks where you have all the limb development, the heart development, all the different parts of your body are developing into what's going to be the basic blueprint of the adult body that's going to be born, or the fetus that's going to be born. So that's when you can have the most teratogenic effects. Some people wanted to pick A, others were just guessing, but B was definitely the most picked answer. It wasn't that hard of a question. Do I feel that the actual step 1 is more similar to UWorld, NBMEs, or a combination of both? No, it's definitely much more similar to UWorld. Yeah, step 1 is definitely much more similar to UWorld. So the thing with that is that UWorld questions are very much just the way your step 1 questions are going to be like, but UWorld as a system is made to teach. So the answer choices in UWorld are all there to kind of show you, you've probably noticed that the answer choices in UWorld are like your differentials, and they teach you why those other answer choices are wrong. Sometimes answer choices are just worded weirdly to teach you stuff, So that's where I guess it becomes a combination thing. The answer choices you have here are somewhat more realistic because they're not trying to teach you in NBME. They're actually testing you. So that's why NBME becomes a good way to gauge yourself to see where you stand when you're preparing for step 1, whereas UWorld is the perfect tool for actually learning and getting explanations for everything and seeing how, where the other answer choices would be correct. But yeah, your step 1 is going to look more like your UWorld questions do than these questions. These questions here are relatively harder than even the step 1 questions for the most part because they don't tell you enough. They don't tell you enough information. I don't know who's writing the questions, but whoever's writing them, the team of people that are writing these questions often tend to word these questions very weirdly, I guess, for a better explanation. But it's a great way to test where you stand because at the end of the day, if your foundations are strong enough, you will be able to pick the correct answer, even though the question might not make enough sense or some information might be missing. You'll be able to fill in the holes, and that's where NBME becomes the perfect tool for actually testing yourself on how prepared you are for steps. Alright, now number 23. This is a renal question. This is a really good question too. So a 46-year-old woman comes to the physician because of a 1-week history of low-grade fever and joint pain. She has chronic headaches for which she takes ibuprofen several times daily. Physical exam shows a diffuse maculopapular rash. Urinalysis shows 2+ protein, some white blood cells, and eosinophils. A renal biopsy is most likely to show which of the following in this patient. Now, before your step 1, you should be able to describe all the renal things in first aid without looking at first aid. So if we look at it real quick right here, this is what I'm talking about. So when you click on pathology, you should be able to talk about what kind of casts you're going to find in different places, and then you should be able to talk about all of these guys, the various nephritic syndromes, the various nephrotic syndromes, and what their key findings are under light microscopy as well as electron microscopy, without having to look at it on the next few pages, right? So the next few pages go into really good breakdowns of who these diseases can happen to, what they're going to look like in LM, immunofluorescence, if there's any immune compositions involved, and electron microscopy. You have to know all of these really, really well to the point where you can talk about them without looking at them, right? And this is also a good time when you're supposed to go back to cardiovascular and look at other related symptoms, go back to musculoskeletal, look at other related symptoms, any diseases they mention. After the psych chapter, if you're doing renal, repro, or respiratory, and they mention a disease that has overlap with another disease from the earlier systems, you should go back and look at them, right, for revision. So our patient really looks like, she's like a lupus patient, right? She's 46 years old. She has chronic headaches, and she takes NSAIDs. So the NSAIDs thing is one set of issues in renal, right? People who take NSAIDs regularly, several times daily, that's one set of issues in renal stuff. It could be something related to that with her. But at the same time, she also has a maculopapular rash. She has proteinuria, which also seems like she might have lupus too. So she's got two different sets of issues that could both be presenting, or either one could be presenting in her renal biopsy, which is what makes this a poor question in my opinion, because they're testing you on two different possibilities. So now you have to see if they have both answer choices in the question. So what would you find on her biopsy? So you look at your answer choices, crescent-shaped glomeruli. When you see crescent-shaped glomeruli, you should immediately know that's related to rapidly progressive glomerular nephropathy, which has a poor prognosis due to rapidly deteriorating renal function. Crescents are full of fibrin and plasma C3b proteins, as well as many cells like parietal, monocytes, and macrophages. And the crescent-shaped stuff, that's usually due to Goodpasture, Wegener, microscopic polyangiitis, and you can see that right in the nephritic stuff right here, right? Rapidly progressive crescenteric glomerulonephritis. This one is related to all these other diseases right here. Goodpasture, where you have autoantibodies to type 4 collagen, it's a type 2 hypersensitivity. Wegener's and granulomatosis of polyangiitis, right? Microscopic polyangiitis, the things we looked at in cardiovascular path. So these are not her problems, so you shouldn't be picking A at all. B is the answer. I'll come back to that. C says mesangial cell proliferation. Well, when you see mesangial cell proliferation, that's a sign of diabetic glomerular nephropathy, where you also have glomerular basement membrane thickening, and you find Kimmelstein-Wilson nodules, right? That's not her problem either, so you don't pick the mesangial cell proliferation. Sclerosed glomeruli. Sclerosed glomeruli, as well as this other answer choice, E, subepithelial deposits in the glomerular capillary walls, these should ring bells for you. Like, you should know exactly what they're talking about. When you see sclerosed glomeruli, that's related to focal segmental glomerulosclerosis, right? That's what they're talking about. Where you think of focal as a specific group of people, black or Hispanic, and diseases like sickle cell, which happens to African Americans, HIV, and drugs, which again are more common, at least in New York, with African Americans and Hispanics, Latinos. Right, so this is just a memorization tool. If anything, it's not that I'm using actual statistics. You just want to use that as a good memorization tool, so that if you ever see focal segmental glomerulosclerosis, I always used to think like focal is like a specific location, right? Foci are specific locations. Segmental is like breaking down, like segregation in a sense, and that always helps me remember African Americans and Hispanics, and it's related to other disease conditions. So if you ever get a question about a sickle cell patient with chronic heroin abuse or HIV, etc., and then they start talking about renal impairment and renal biopsy, you think of this. You're going to see sclerosis, hyalinosis. I also used to call this focal segmental glomerulohyalinosis, right? It's just, you can call it either thing, sclerosis, hyalinosis. Those are both things you're going to see on light microscopy here. So none of those fit. E is the last one. This doesn't fit either. When you see subepithelial deposits, you're thinking deposits of really significant immune complexes, right? And although that is related to lupus, it's this question is fucked up because I told you, as I said in the beginning, they've combined two different things, so they better not have an answer choice for both things, right? But they do. And there was only one way to really figure out what the real issue was. See, choice E is related to membranous nephropathy, which has a spike in dome appearance on electron microscopy due to subepithelial deposits and is related to lupus, right? But for her, they did a really significant thing by telling you that she takes ibuprofen several times daily, and that should have been the bigger marker for you, apparently, than the lupus part. So if this was a UWorld question and you locked in your answer, you would probably see that 50% chose B and 50% chose E, or something close to that. But this was a messed up question, because how would you know, in all honesty, if we're trying to find a renal biopsy relevant to her ibuprofen several times, or a renal biopsy relevant to her lupus? Okay, and they didn't give anything that would really break down specifically to the ibuprofen. But what I saw online was that some people said that the fact that there were eosinophils tells you that she's having a type 4 hypersensitivity reaction or something. So remember, in type 4 hypersensitivity, something is acting as a hapten, right? This patient most likely has lupus, but her renal issues are due to her excessive ibuprofen intake, causing acute interstitial nephritis, something that is on every NBME. We've talked about it in the previous NBME explanations, and we've revisited this page so many times because I tell you guys that you really need to make sure you're able to talk about this page and the first thing on the next page without having to come to this page at all, right? Acute interstitial nephritis in patients taking any of these medications, but most commonly you see it with NSAIDs a lot, and you see how it's also relevant to lupus. So that overlap really was supposed to be what you needed to work with for our question, not just lupus. ATN, acute tubular necrosis, often related to hospitalization. You're going to have patients with oliguria and granular cast, and either one of these images can be given. And then renal papillary necrosis, where you actually have slowing of actual papilla, right, or papillae in sickle cells, and again, patients who take NSAIDs. So both renal papillary necrosis and AIN, they do present differently, so the difference is going to be obvious when you look at a question. And then this has been a topic that's been in every NBME too, right? Renal artery stenosis, usually bilaterally. So our patient is an AIN patient, right? She's going to have tubular interstitial nephritis because her NSAIDs are going to induce hypersensitivity by acting as a hapten, right? It's azotemia occurring after administration of drugs that act as haptens, and that, I guess, kind of hypersensitivity stuff is the reason she has eosinophils as well in her urinalysis, right? Whereas apparently you wouldn't find eosinophils in just lupus-related answer choice E. But I do agree that, this is kind of slightly mean that they have both answer choices there. This should have been some other answer choice not related to lupus at all. Because, in all honesty, it is possible that her renal biopsy might actually show you this, because she has lupus. And she might not have any issues at all from the ibuprofen several times. So it's a messed up question because it has both things. But, again, both things were related to tubular interstitial nephritis. So I guess in that sense, if you remember, if you're that solid with your medicine, then you'd be able to pick this correctly. When I did this question, I did decide, that I would focus more on the fact that they wrote it like this. She takes ibuprofen several times daily. So I went with answer choice B, but I was almost sure I was going to get it wrong until I, did this explanation, and then I saw that B was the correct answer. So remember that I told you guys yesterday, as I'm going through these, when I made these explanations, I did look at the questions and pick what I would put as an answer. So each one that I've gotten wrong, I actually wrote that, what I would put. So like number 10 I did get wrong. I would have put A for this, but it was actually D. So far, that's the only one, up to question number 23. Now, 24. I got 25 wrong, too. Excuse me, guys. Okay, so 24. A 2-year-old boy is brought to the physician because of a 2-day history of fever, sore throat, and rash. His temperature is 101.7. There's a widespread red sandpaper-like rash over the extremities. The sandpaper rash is a giveaway for the scarlet fever stuff. A purulent exudate is seen over the tonsils. He receives the diagnosis of strep pyogenes, which is obvious. Which of the following streptococcal components is the most likely cause of the skin findings in this patient? Hey, Casper. Yes, I'm going to continue. Right now, I have paused at neuropharmacology, but I'm still waiting to not be so sick anymore. I really don't want to be sneezing my nose the whole time I'm streaming and coughing and whatnot. I'm just not sure what's taking so long for me to just be better, but I guess these are the symptoms that go away last. So once my cough and sneezing are gone, I will definitely continue on. I might actually be live later on today to continue on with the neuropharmacology stuff as well. Yeah, but I have to finish that playlist this month because next month I'm going to start preparing with the CK materials. So, yeah, I will continue though. Sorry for taking so long. If you're waiting on a chapter that's afterwards, so let me just actually show you guys real quick something. So, if you go to my channel right here. So if we go to my channel, right, if you click on anywhere, you click on my channel, you come here. If you go to playlists, you can see all my different playlists. And the main thing is I do have this systems section over here. These are videos I made from before doing Amboss integration. So I do have respiratory and all the other things already uploaded. There just aren't Amboss questions in it. So if you're taking the test soon and you really need something, you can definitely watch these videos. They're all using First Aid 2019. So everything after Psych, I was using First Aid 2019, and you'll know because it'll say right here First Aid 2019. So you'll know I'm using the 2019 book. If it doesn't say that, then I'm using the 2018 book. But I stopped using the 2018 after I was up to, I believe, Psych. Yeah, Psych was where I started using the 2019 book. In the full FA playlist, the only new thing is the heavy amounts of Amboss material. I have everything from Amboss in there, and Amboss was amazing because Amboss has really good pictures, really good x-rays, and they like highlight things in x-rays so you can actually learn what to look at, especially when it comes to respiratory. So the newer respiratory videos definitely will be a lot better, but as far as anything, if you really need respiratory videos, you can definitely watch the older ones. So this question is just asking 24, what is the causal component of strep pyogenes, right? And you look at the answer choices: capsular polysaccharide, erythrogenic toxin, hemolysin, hyaluronidase, streptolysin S. If you don't remember your microbiology well, you're not going to get this correct. Those answer choices are actually pretty confusing if you don't remember what happened with strep pyogenes. See, strep pyogenes does have a capsule, right? This is the sketchy micro image. In the sketchy micro, the capsule is always represented by some kind of covering like this. But that capsule is not the thing that's causing the issue. In the book itself, they actually tell you the answer, right? This is coming straight from first aid. Erythrogenic toxin is the thing that actually causes scarlet fever, which is what our patient has. Scarlet fever looks like this. So you can see the sandpaper rash they're talking about. That's what they're mentioning. Now, if you look at all the answer choices, capsular polysaccharide and hyaluronidase are actually pretty much the same thing, right? That's what the HA here was for. So that's not what's related to scarlet fever. Scarlet fever is due to erythrogenic toxin. You just have to remember that, and you would just see it right here. If you remember that first aid page, if you have that visual memorization of the first aid page, then you'll definitely remember it, right? And I've revisited this little section so many times that I definitely remember everything from this page. And that's how you're supposed to memorize this: repetition, right? Every time you're doing a question, every time you're doing any kind of reading where they mention strep pyogenes or scarlet fever or rheumatic fever even, you should come back here, right? Because even rheumatic fever, remember in older first aids, rheumatic fever was mentioned right here, but they don't do that anymore. They moved it to its own section. So rheumatic fever was also relevant here, and remember that rheumatic fever is a type 2 hypersensitivity, whereas the post-streptococcal glomerular nephropathy, depicted by this guy holding the penicillin pencil, this glomerulus, 2 weeks after the infection on this calendar, and cola-colored urine, and a puffy face, all of that is related to the type 3 hypersensitivity that occurs after strep pyogenes. Also remember that strains that cause impetigo can also induce glomerulonephritis. Right? The superficial infections can also cause glomerulonephritis. However, superficial infections will not cause rheumatic fever. Rheumatic fever only occurs after the pharyngitis. Right? Pharyngitis can result in rheumatic fever and glomerulonephritis. Very important difference to remember. Okay, Dunga Lakshmi has a pretty good question. So it really depends on. Honestly, my suggestion would be do NBME 18 first, then do the explanation, right? That's the main concept there, because everyone that does NBMEs, when you finish the NBME, all you'll ever know is the correct answer, but NBME doesn't tell you the explanation. So these videos are definitely much more beneficial after you finish the NBME. So if you did NBME 18, you would finish your NBME 18, then you would come back here and you would look at this explanation stuff, right? And my questions are not going to be in the same order as your questions, but it's okay. You would just learn from this video instead. You know you already did the question. You'll probably remember whatever you remember, but you'll still learn nonetheless. If you're not planning on doing NBME 18, then this video, the NBME 18 videos, really help you understand what you're preparing for if you need to take an NBME, right? So whether or not you watch it before or after really depends on whether or not you're going to do that NBME. I also have explanation videos for 20 and 23 that are already done. If you're not planning on doing either one of those videos, you can watch those to learn what you're expecting when you finally sit down for NBME, what kind of knowledge base you need to have, and stuff like that. Okay, so that was number 24. 25 was a really messed up question because, no one teaches us this stuff. As far as I know, I wasn't taught this. But this link does a really good job, so let me share the link right here. And this question I did get wrong because I really didn't know how to approach it. So they tell you here, a 35-year-old woman who's being examined because of infertility receives an injection of contrast material into her cervix to visualize the reproductive tract before undergoing radiographic tests. On the hysterosalpingogram shown, the contrast material, as indicated by the arrows here and here, is also seen in the peritoneal cavity. Which of the following best explains this finding? So you look at it, you can see the uterus, you can see the fallopian tubes, right, in both directions. Something funky is happening on this side, and then the arrows are pointing on, like, the right side is over here, so the R is there, and the arrows are pointing at showing you all the leakage into the peritoneal cavity. So I looked at the answer choices. It was either rupture of the fallopian tube, which again I was inclined to think there might be a rupture because this does not look the same as this side. I was also inclined to think rupture of the uterine body because I felt like maybe that's why she's having infertility, and because there's a rupture in the uterine body somewhere, that there's been leakage of the contrast into the peritoneal cavity. Then there was answer choices C and D, both which said spillage of contrast either as an artifact or because it's normal. Now, as far as I remember, the word artifact is often used when you prepare a slide for light microscopy. An artifact is basically something that just happened while you were preparing the slide. That is not actually significant to what the pathology of the slide is. It's just an artifact, right? That's kind of how you use that word. So I did not think that C was a word or answer choice that fits this at all, right? This is more of a hysterosalpingogram kind of thing. Not what we're looking at. So I would have put B, right? I thought the answer was B here, but this is actually D. This is spillage of contrast, which is normal in a hysterosalpingogram. Now, if we look at the link that I just shared, right, that's actually a really cool page from a medical school that I guess actually teaches this stuff, right? And they tell you a lot about hysterosalpingography. And if you look for the word spillage, you could see. Right, you can see right here, spillage of contrast into the peritoneal cavity. You're supposed to document whether or not there is, right, whether there is normal spillage of contrast into the pelvis, right? So it's supposed to be normal. Any spillage into the pelvis or peritoneal cavity is supposed to be normal. And then they give you a bunch of images. So image 1 here, right, this one is showing you an early radiograph from a normal hysterosalpingography, right? The white arrowhead is pointing towards the uterus, which is filled with contrast and is normal in shape. The white arrows pointing towards the right and left fallopian tubes are both beginning to fill with contrast too, so that means they're working, or they're there. They are patent. Image 2 is another one. This one you can see the white arrows are pointing towards the dark radiodense material that is spilling from both the right and left fallopian tubes. The arrows are pointing towards the triangular shaped areas of contrast, which represents extravasation into the peritoneum. It forms a triangular shape as it flows, and this is also a normal hysterosalpingogram. Remember that your fallopian tubes end at an open ending. They don't actually connect to anything, right? So fallopian tubes go to an open ending, and they're very close to where the ovaries are. Ovaries throw the egg into the opening, and then the egg has to kind of find its way into the fallopian tube. But there is some open space in between the two. It's not like the fallopian tube is directly connected to the ovaries. So that's why there's spillage there as well. Now, this is the abnormal hysterosalpingogram. You can tell it's abnormal because you can't really see on both sides the fallopian tubes, right? So here the white arrowhead is pointing towards the uterus, which is normal in shape and is filled with contrast. This white arrow is pointing towards the right fallopian tube, which has begun to fill. However, the left one is not filling, right? So there's some kind of issue with the left fallopian tube. And here, this is also another one. At a later point in time, the image shows contrast spilling from the right fallopian tube into the open peritoneal cavity, which is normal, right? Note that the left fallopian tube did not fill with contrast. This is the same patient still. They're just still filling, and they can see the leakage happening, the spillage happening. So this is what you're supposed to take away. I did remember after doing the question that the fallopian tube doesn't connect to the ovary, right? So that's why there's spillage on both sides. And I didn't think of that when I read the question. So that I actually have taught before. I don't remember where the picture is, but let me see if I can find it. I think it's much earlier. Oh, right here. Okay. Yeah, I mean, first aid has the picture too, right? So you can see your fallopian tube is here, there's an opening. You see, they're not like completely attached or connected or anything. So all the contrast that's entering the uterus is going through the fallopian tube and then coming out here and spilling into this open area. Right, this open area. And we once did a question about the peritoneal cavity. Yeah. Right, the ovum is released into the peritoneal cavity and gets actively sucked into the uterine tube. And if you have bleeding in this weird area in between the two areas, you can have exsanguination where you just bleed to death. Right, so that's a question that I think UWorld had once, that you can actually have some kind of internal bleeding there in the peritoneal cavity from some kind of ectopic pregnancy, right? Where if the egg didn't actually enter and just stayed here somewhere, and the sperm made it all the way here, and you got an ectopic pregnancy in this peritoneal area, the mother can actually die because of just bleeding to death. So, although this question was a little fucked up because we don't really look at hysterosalpingograms much in med school, or at least not in mine, it was still a pretty fair question in the sense that you could kind of figure out there must be spillage because the fallopian tubes are open. How many you take really depends on you. But I would say do like, any of the newer ones after 20, so 21, 22, 23. I think it's up to 25 now. I'm not sure, but you should do the newer ones for sure because I don't know. I just feel like the newer ones are more relevant, I suppose. But I'm pretty sure people that are actively out there actually taking NBMEs would probably be able to tell you better. If you're planning on taking NBMEs on your own at home, offline, then you can do as many as you want. It's just going to be more and more practice. So if you have the offline forms of NBMEs, time yourself and do them as if you're actually at Prometric. Do as many as you can. The more you do, it can only benefit you. You're going to be exposed to more questions. You're going to be exposed to more explanations. And doing this, what I did right here, like finding the correct explanation for each question, is actually a form of studying, because as I'm doing it, I'm starting to feel like my knowledge of these things is becoming a lot better. So this is something that people should be doing, and I understand that a lot of people don't have time to, so I'm doing it here and posting the videos as is, so you could learn it at least, even though you couldn't go find the explanation yourself and put in the hard work of actually, gathering everything up. Watching the video of me doing it will also be just as helpful, and you get to see the connection, you get to grasp the concepts. But you should do as many as you can until you start answering most questions correctly and you start feeling a lot more confident. 26. A 48-year-old woman has had gradual onset of back pain over the past 2 weeks. There is no history of trauma. She does not smoke cigarettes, drink alcohol, or use illegal drugs. Hemogram, serologic studies, and urinalysis are unremarkable, so those are diagnostic information. An X-ray of the spine shows 2 lytic lesions, one in T10 and the other in L1. Which of the following is the diagnosis? So you look at all your answer choices, and you should understand that if they told you the hemogram, serologic studies, and UA are unremarkable, they're all normal, then you got to make sure whatever answer choice you pick should have normal hemogram, serologic studies, and urinalysis. So you look at avascular necrosis, which is usually avascular necrosis occurs almost anywhere, but usually the question is going to be about avascular necrosis of the femur. I think Legg-Calvé-Perthes disease or something like that is the longer name of that. And that's definitely not what she has, so I wouldn't pick A. The correct answer here was B, but let's keep going. C, osteosarcoma. Okay. Osteosarcoma, although it could occur with normal hemogram, serologic studies, and all that, it doesn't occur at these areas of T10 and L1. That usually occurs at let me show you what I'm talking. It occurs like in the long bones of your legs and stuff. So this page tells you the lab values, right? And you can see osteosarcoma is not really here, right? But osteosarcoma is a cancer that you start seeing right here, and you see how you have to remember the Codman triangle thing. You have to remember how it occurs in the metaphysis of long bones. Right, so it's not really relevant to our patient. Not relevant to our patient at all. She has back pain. Renal osteodystrophy would not have a normal serologic study. Renal osteodystrophy is actually it's a condition where your kidney is actually trying to do the best it can, right? But it really can't do much because you have an endocrine problem. So let's take a look at renal osteodystrophy. Right here. Right, so renal osteodystrophy, they mention, yeah, see, hyperparathyroidism. Renal osteodystrophy is where you have renal disease that leads to secondary or tertiary hyperparathyroidism, and then that causes bone lesions. Right, and this is explained more under renal section, page 656, so let's take a look at that. 656, renal osteodystrophy, right here, right? Hypocalcemia, hyperphosphatemia, failure of vitamin D hydroxylation, all of which would cause her to have messed up lab values associated with CKD, leading to secondary hyperparathyroidism and possibly even tertiary. There's going to be high phosphate because you can't respond to PTH, so you're not trashing your phosphate, and the high phosphate can bind with the calcium, leading to tissue deposits. So you have low serum calcium. Right, and then you have vitamin D is going to be low because you're going to have low vitamin D because your kidney's messed up, and without the vitamin D, you can't even absorb new calcium. All of this ends up with subperiosteal thinning of the bones, and that's not what our patient has. And again, thyroid carcinoma, once again, completely irrelevant. With thyroid carcinoma, the hemogram and the serologic studies would not be normal. So you're only really left with answer choice B, metastatic carcinoma of the breast, which does fit her, right? She could have breast cancer, and it might have metastasized, and that's exactly what happened to her, right? The only explanation left for her two distinct lytic lower back bone lesions is the metastasis from the breast. That page, I have an AMBOSS question about this too, page 509. Let's take a look. So there's an AMBOSS question apparently. Oh yeah, this one down here. Right, look at this. This is also a similar type of thing. So 52-year-old woman comes to the physician because of lower back pain for 1 week. The pain is constant, severe, and dull in quality. She does not recall any trauma and has not had any urinary or fecal incontinence. She has had a 20-pound weight loss over the past 6 months. Physical exam shows localized tenderness over the lumbar spine, similar to our patient. An X-ray of the spine shows a vertebral compression fracture at the level of L1. Further evaluation of this patient is most likely to show which of the following findings, and the answer was spiculated density on mammography. Right? Unexplained weight loss and a pathologic fracture of the vertebra without a history of trauma should raise concern for an underlying malignancy that has affected the spine. Breast cancer is among the most common malignancies that metastasize to the bone, along with lung, thyroid, renal, and prostate in men. Bone metastases from breast cancer can have both lytic and blastic lesions. Alright, so that's the issue with this patient right there. 27, a 47-year-old woman develops an irregular, raised, multicolored, dark lesion on the area of her left forearm that is frequently exposed to direct sunlight. Examination of tissue obtained from the biopsy shows malignant pigmented cells, which now you know, right? They pretty much told you the ABCD stuff, and they tell you it's malignant, so it's definitely melanoma. Involvement of which of the following skin layers is associated with the greatest risk for an unfavorable prognosis? And a lot of people fell for the bait answer choice A, basement membrane, right? When something invades the basement membrane, you start thinking that's malignant. But that's more so true of things like squamous cell carcinoma or stuff like that, you know, when things invade the basement membrane. But for melanoma, the answer was actually E. And you would remember this if you saw the image that, I think it was First Aid that shows this image right here, right? Melanoma, yeah, it's UWorld, not First Aid. UWorld shows this image right here, right? Melanoma depth of invasion. There's something called the Breslow depth and the Clark level associated with that depth. And you can see the highest Clark level is the one where you're invading the subcutaneous fat, which is Breslow depth 5, right? 5 millimeters depth. So once it invades your subcutaneous fat, that is when it becomes the biggest issue. Melanoma, right? S100 tumor marker, just like our other disease we looked at, the Langerhans histiocytosis. Associated with sunlight exposure, like our patient. Look for the ABCDEs, where they told us asymmetry, border irregularity, color variation, big diameter, changing over time, right? Evolution. And they tell you right here, depth of the tumor correlates with risk of metastasis, but they don't put it into words in First Aid, but UWorld visualizes it for you. So that's why I put this picture here. the depth can go all the way to subcutaneous fat, and that's where it becomes a problem. Right, so answer choice E. But everyone fell for A. A lot of people fell for A. 28. A 6-year-old girl is brought to the emergency department by her father because of a 15-minute history of shortness of breath, severe shortness of breath. The father says that she was diagnosed with a throat tumor 3 years ago. Her respirations are 32 per minute. Physical exam shows a nasal flaring. Laryngoscopy shows multiple raised finger-shaped lesions arising from the vocal cords and the epiglottis and partially occluding the larynx. The lesions are excised. Microscopic examination of one of the lesions shows finger-shaped fibrovascular cores lined with benign squamous epithelium. Which of the following is the most likely cause of virus? When you see some shit like this, don't waste much time. Immediately go with human papillomavirus and just move on. That's what this is. This is HPV. And this is actually taught by UWorld too. So what you need to know is the actual epithelial lining of your vocal cords. UWorld had a question about the true vocal cords versus false vocal cords and how they're different. This is actually HPV. So let's take a look at that UWorld question too. I haven't done it in the new videos, but it's been discussed in my older videos. So when we go to respiratory, this is after page 647, but this is in my PDF, it's not in first aid. So this is the question from UWorld right here. I don't know if they still ask this question, but this was an interesting question. I got it correct when I did it, so this is my own image right here. So it says a small DNA virus is described that has affinity for stratified squamous epithelium. The virus is most likely to affect which of the following respiratory structures? And the answer here was your true vocal cords, right? So of the answer choices listed, the true vocal cords are the only area covered with stratified squamous epithelium. The virus described could be human papillomavirus, which can cause warty growths, papillomas, and papillomas are what they're describing as the finger-shaped bullshit, on true vocal cords, producing hoarseness and possible stridor because of upper airway obstruction. Right, so now if we look at it, this is how it looks like if you actually look into a person's mouth. So you have the base of the tongue, you have your epiglottis, you have your false vocal cords outside, and then the true vocal cords right there, right? And that's what kind of defines your glottis as well. So you can see how the glottis opened up. These are your true vocal cords on both sides. Inner lining of the trachea is right there. And you have something called the corniculate cartilage, which is this one outside. Right, so this is the basic anatomy of that area. This is another image showing you a different view of the same stuff. So epiglottis, false vocal cord, and your true vocal cord. Right, the true vocal cord is the one that has your vocalis muscles in it. Right, your false vocal cords do not have any muscles in it. And right after that, outside, you can see your thyroid cartilage and your trachea. Right, so I think I was also able to find images on Google, HPV true vocal cord. So when I searched online, you can see what we just looked at, right? This is what we were just looking at. So you see your true vocal cord, right? And they're showing you a cyst here. This is another one showing you the same kind of things we were looking at right now, right? So as far as papilloma, right, that's what they're kind of talking about. They keep referencing it as finger-shaped or whatever. That's pretty unreal. You don't really see it like a finger per se. But yeah, you know, good images. Very real question. Definitely something that you might have not caught before. You might not have seen it before in a question. So worth knowing. But again, you could also cancel out other answer choices. CMV, Epstein-Barr virus, and herpes do not have anything to do with this. HSV1 is related to the brain. HSV2 is related to sex. Neither of them actually cause that kind of warty stuff in your vocal cords, right? Epstein-Barr is related to kissing and a lot of lymphadenopathy. Cytomegalovirus is the cyte and the megalo, right? Everything. You have to remember what those words stand for. You can have blindness, you can have hepatosplenomegaly, you can have a bunch of different issues with cytomegalovirus, and you have to remember them, right? When you think of cytomegalovirus, you should, as usual with anything, you should think of the sketchy microimage if you can, if you've done it. If you haven't done it and you have time, I would recommend doing it. But this is it right here. Right, this is the sketchy microimage. So you can see this big cave looks like a mouth. So it's supposed to remind you of the febrile pharyngitis, right? And all the bats in there with the red eyes remind you of the conjunctivitis, pink eye, right? This kid over here drowning in blood, that's actually a sign of gastroenteritis, right? And the blood is actually coming from this naked statue of David to remind you that it's a naked virus, right? No envelope, naked virus. He's the one bleeding from his urine to remind you of the hemorrhagic cystitis, right? So there's a bunch of stuff. These images are actually really wonderful in helping you remember that. But look, this image is not pointing at the vocal cords or anything. You're looking at the febrile pharyngitis. Alright, number 29. They love bringing this shit up too. Especially, like, you know, just making sure you know all these tiny little parts of proteins and whatnot. Because how else could you be a doctor without knowing that? So a 32-year-old man with an X-linked recessive disease has deafness, hematuria, and progressive renal failure. He most likely has an abnormality in which of the following proteins. Now, I did answer this question correctly, but I didn't know what was actually happening. In this question, they tell you it's X-linked recessive, right? And you should remember all your X-linked recessive diseases. They're actually taught to you as a list of shit on page 61. Right? These are all your X-linked recessive diseases. Ornithine transcarbamylase deficiency, Fabry disease, Wiskott-Aldrich. If you don't remember what Wiskott-Aldrich is, the WH remind you of the WASP gene, and it was something in immunology. Ocular albinism, right, which would have the blindness as well. G6PD deficiency, the most high yield of all of these. Hunter syndrome, Leishman, hemophilia, Bruton's, and Duchenne and Becker. Okay, our guy, in my opinion, I couldn't tell which one of those he has. I don't think any of them actually cause deafness, so I don't know what he has. However, the fact that they said it's an X-linked disorder also related to progressive renal failure and hematuria, that helped me understand that it must be H, type 4 collagen. Most of these you don't even find in the kidney, and the others won't even be related to hematuria. But if you have autoantibodies against type 4 collagen, that kind of helped me remember something. It reminded me of Good Pasture. Good Pasture has a bunch of issues. It does not have deafness though, but that's what my thinking was. So when I was looking at this question, I was like, the patient has hematuria and renal failure, and of all the answer choices, only type 4 collagen is relevant. Antiglomerular basement membrane antibodies against type 4 collagen define this type 2 hypersensitivity, Good Pasture syndrome. However, Good Pasture syndrome is not X-linked recessive, so that's not what they're asking about. Alport syndrome, however, is also another thing related to type 4 collagen, and it has deafness and hematuria, but this one is X-linked dominant. So maybe the test writer meant to write X-linked dominant disease? I don't know. This might be some other disease, but I could not find out because Good Pasture is not X-linked recessive. I really think the test writer meant to write a question about Alport syndrome and meant to write X-linked dominant, but I'm not going to ever find out. Now, what are these other answer choices? You should know most of them. I'm going to explain the ones you don't know. Osteocalcin, you might not have heard of before. This is also known as carboxyglutamate acid containing protein. Really big thing, right? Osteocalcin is a non-collagenous protein hormone found in bone and dentin, first identified as a calcium binding protein in chick bone. Because osteocalcin has GLA domains, its synthesis is vitamin K dependent. So the only way this thing is ever going to be relevant in a question is if you get a question about something related to bone or calcium binding and vitamin K deficiency. That patient might not have any osteocalcin, worsening their calcium binding capabilities. Laminin and fibronectin has been in answer choices so many times, and I keep bringing you back to this page to remind you of hemidesmosomes. Right? Hemidesmosomes are made of integrin and laminin and fibronectin. Okay, so that was not relevant either. These would be the correct answer choices for a disease like the bullous pemphigoid. Bullous is below, right? So bullous pemphigoid. Antibodies against these things, that would be relevant. Even the keratin stuff could possibly be relevant. But, again, it's not what's happening to our patient. They don't mention those things. They're just talking about hematuria and progressive renal failure. Thrombospondin, right? Thrombospondin. Tropoelastin is related to muscles, so you should know that one. But thrombospondin is a subunit of a disulfide-linked homotrimeric protein, and it's a protein that acts as an adhesive glycoprotein for cell-to-cell and cell-to-matrix interactions. The fact that it has thrombo in it should make you think of platelets and how they kind of bind with each other, so that was also irrelevant. That's about it. 30. This was this was an interesting question. A 25-year-old woman comes to the physician because of a 2-year history of intermittent, diffuse, cramping lower abdominal pain. The pain is usually associated with 2 to 6 days of loose, watery stools and is typically relieved with defecation. Between these episodes, her stools are normal. Her vital signs are within normal limits. Physical exam shows no abnormalities. Lab studies, including CBC, metabolic panel, and thyroid function tests, show no abnormalities, which is, again, remember, very diagnostic, right? So her physical exam and labs are completely normal. That tells you a lot because then you can knock out answer choices where those things should not be normal. A drug targeting. Which of the following mechanisms of action is most appropriate for this patient? Now, I personally had not actually known this before doing this question, but when I read the question, I figured this is some kind of constipation or diarrhea, but I couldn't really figure it out, right? She has intermittent diffuse crampy lower abdominal pain. She has 2 to 6 days of loose watery stools, but look at it, she's not eating anything, she's not sick. It's not like a diarrhea related to some kind of infection, so it must be psychological, at which point I realized it's probably IBS, irritable bowel syndrome, right? They also tell you she has a 2-year history of it, but it like happens in different times, right? It's kind of like it happens and she's back to being normal. So she has episodes most likely related to stress because she's actually very young, so it could be work-related stress, dating-related stress, anything like that. So we need to give her a medication that most likely helps her with the stress, not so much with her bowel problems, right? And then I looked at all the answer choices. Remember the concept of which one is least like the others? So immediately, like things like answer choice C, inhibition of colonic water reabsorption, so that you can actually poop more, would be wrong, right? That's a beta of an answer choice. This is more like kind of like a laxative kind of thing right here. It's like a stool softener, right? C, and that's not what we're trying to get for her. Accentuation of bowel salt reabsorption, that's completely irrelevant. That would be more for like some medication related to cholesterol issues. Inhibition of 5-hydroxytryptamine. This thing, answer choice D, is some kind of serotonin antagonist like ondansetron or cyproheptadine, and those are not things we need for her. Ondansetron is used as an antiemetic in chemo patients, and cyproheptadine is used for serotonin syndrome. So that's not for us at all. And the inhibition of TNF-alpha, come on, like those are drugs used for IBD, right? Like Crohn and all that, rheumatoid and many other things. TNF-alpha inhibitors are not what we're trying to give this patient. So, and by the way, I do want to show you guys so you always remember what your TNF-alpha inhibitors are because those have very interesting names. So those are your adalimumab, sertolizumab, right, golimumab, and infliximab. These are the medications you're supposed to give for IBD, rheumatoid, psoriasis, stuff like that. Okay, but that's not what we're trying to do. Our answer here at that point had to be B, right, which looked like something related to neurology. So I picked it and I moved on. The other answers didn't make sense to me and I was correct. Right, so IBS most commonly presents in middle-aged women with episodes of constipation or diarrhea with no structural abnormalities, like her. First line of treatment is lifestyle modification and dietary changes, which is what first aid tells you. However, loperamide is a mu-opioid agonist that slows gut motility to treat this kind of diarrhea. I didn't know that, so let's take a look at both things. 416 is your IBS. Here they don't tell you any medications. Right, goal is just symptom control. There's no rectal bleeding, tenesmus, weight loss, greasy stool, or any other red flag symptoms. This has a huge psychiatric component. Right, no structural abnormalities, and that's what our question told us. Now, loperamide, that's on page 433. So, right here, you can see loperamide is used for diarrhea. It has poor CNS penetration, but they don't tell you here that it's used for IBS, but it is. Okay, so I looked online, it actually really is. It's just not taught in first aid or anything like that. So, totally worth knowing. Make sure you remember that. Don't get confused. 31. A 35-year-old man is brought to the physician by staff of the group home where he resides because of worsening behavior for 2 weeks. During the interview, he tells the physician that he believes the CIA is spying on him through his television. He then reports hearing voices in the hall outside the examination room and states that the CIA now plans to kill him. He appears disheveled and unkempt, hair and poor hygiene. He has difficulty answering the physician's questions because he seems to be listening to some internal stimuli. Mental status examination of this patient is most likely to show which of the following findings. Very interesting question, right? Very interesting question, because when I read this question, I was like, all right, so what am I even thinking of? Because I usually try to have an answer ready in my mind before I look at the choices, and I couldn't figure something out for this one before looking at the questions. I do believe that this question was incorrectly worded, because either that or there's something missing in my knowledge or in first aid, but this is actually schizophrenia. However, they only gave you a time frame of 2 weeks in this question, and that falls under a brief psychotic disorder, right? So this patient has had symptoms for 2 weeks, so this falls under a brief psychotic disorder, where you have a few positive symptoms like delusions or hallucinations and bizarre behavior like our patient. However, he's also unkempt with poor hygiene, and his cognitive skills are reduced due to the voices he hears. So if this lasts more than 1 month and goes on for 6 months, between 1 to 6 is called schizophreniform. After the 6 months, it's schizophrenia. He might actually have had schizophrenia for a very long time, which is probably why he's living at this group home, right? He's pretty much essentially homeless, so he lives at a group home, and that's probably why this question is kind of worded the way it is. Like, he actually might have schizophrenia for a very long time, and we're supposed to assume that from the fact that he's living at a group home. Now, why is it significant whether he has schizophrenia, schizophreniform, or brief psychotic disorder? Is because those other guys do not have negative symptoms. See, if you look at all the answer choices, inability to state his name, inability to write his name, lack of orientation to place or time, and long-term memory impairment are not really things related to schizo. He probably will tell you his name. He could probably write his name too. He's going to know what day or time it is for the most part, and long-term memory should not be impaired. Those things are related to other issues. He will present with a flattened affect. The way I saw this, I was like, this is talking about some kind of psychological issue, right? Not drug overdose, not alcoholics, not a neurological issue like Alzheimer's or Parkinson. So he's going to have some kind of psychological answer choice, and the only one here that, to me, looks like a psychological thing, something you learn in psychology, is the flattened affect. Now, if we go to page 606, which is 548 in your first aid, 2019, schizophrenia, spectrum disorders, right? You can see here the breakdown. Brief psychotic disorder, more than one positive symptom, lasting less than 1 month. Okay? Then schizophreniform, more than two or more symptoms lasting 1 to 6 months. It could be positive or negative. And then schizophrenia is the one that has both positive, negative, as well as all three, as well as cognitive issues, right? Diminished working memory, inattention, inability to make plans and stuff. Nothing about time or name or writing, stuff like that. So our patient would have this one, the negative flat affect, negative symptom, right? Social withdrawal, he already looks like he has that. Very weird, very weirdly worded question, but definitely not one that's ridiculous, I guess. But you have to understand that NBME questions are very, I guess, real life kind of thing, right? Just because a patient is presenting for something with 2 weeks doesn't mean that he hasn't possibly had another disorder for more than 2 weeks. Okay, so that was just a 32. I got 32 wrong. I didn't know what was happening. 32, a 70-year-old woman comes to a physician for a routine pelvic exam. During the speculum examination of the vagina and cervix, the Valsalva maneuver causes a bulge of the anterior vaginal wall. Which of the following is the most likely cause of this finding? So I read the question, I was like, a bulge in the anterior vaginal wall. Now, I couldn't imagine the anatomy, right? I've done the speculum examination before, but I couldn't imagine what anatomy they were talking about. What kind of anterior bulge are they talking about? And in my mind, I could imagine this. I can definitely imagine this. I can imagine the speculum. And they're talking about an anterior bulge, and I didn't know what they were talking about, right? Because we're looking into the vagina. So an anterior bulge is going to be like this, right? So something is bulging onto the vagina. You see what's happening in this image? So you're putting in a speculum, you're looking into here, and this should be perfectly fine. But in our patient, when she does a Valsalva maneuver, this happens, right? That's an anterior bulge because something, has lost its integrity. This wall here has lost its integrity, and the bladder is pushing onto her vagina. That's what's happening there. Okay. Other than that, you can see the uterus, the fallopian tubes, and the ovaries. Everything else is there. So I couldn't think of that. When I looked at the answer choices, I knew it was not a Bartholin gland cyst. Did not know what a cystocele was, which is what the answer is here. Knew this is not an obturator hernia. Did not know what a rectocele was either. And I went with uterine prolapse. I thought that's what the answer was. Okay. But then this is what a uterine prolapse is. So same thing again, right? This is just a mirror image of this image, but again, same thing. So you have your, you would put the speculum in, you would look at the vagina, right? This is your bladder up here. This is with the normal position of the uterus, all the way up here. When it prolapses, just like anything else prolapses, it means it kind of moved down here. This would also be accentuated by the Valsalva maneuver, but it wouldn't look the same. This is not an anterior bulge. This is actually the whole vagina being full with the uterus, right? The uterus came into the vagina. That's what a prolapse is. So I was wrong. I didn't know that this is what a cystocele is, right? So a cystocele is when your bladder pushes down onto your vaginal wall, and this is the anterior bulge they're talking about, okay? The only other answer choice here that I don't have an image for is the rectocele. So the rectocele is basically the same thing from the other side, I guess, right? So like this image, you see? So this would be called a posterior bulge, if anything, where the rectum, right, it's the wall has become weakened, so you would put your speculum in, you're looking at the vagina, but there's this bulge from behind. That's the rectocele. Right, so I knew not to pick this answer choice because that's not what, that's not what we're looking at for our patient. Our patient has an anterior bulge, not a posterior bulge. So, actually, I don't need this. I already have this picture for the cystocele. So yeah, so those are all the different anatomical answer choices we have here, basically. So I didn't know. I got this answer wrong. I put uterine prolapse, but I couldn't think of what a cystocele could be. But it's a cystocele if it's the bladder that's pushing onto the anterior vagina. All right. Excuse me. This was a cool question. I got this right too. 45-year-old man comes to a physician because of a 6-month history of progressive shortness of breath with exertion. He has a history of frequent nosebleeds since adolescence. He's 5 feet 10 and weighs 175 pounds. BMI is 25, so he's not obese. Physical exam shows the findings in the photograph. So they're showing you these, petechia on the tongue in a sense. And this is your Shamrot sign, which is a sign of hypoxia for the most part. Physical exam shows the findings in the photographs. Inhaled albuterol does not improve his symptoms, so it's not asthma. Which of the following is the most likely cause of this patient's findings? So immediately you could not get answer choice D because it's not asthma, right? That's reactive airway disease is basically asthma. It's not a thromboembolism, so you cannot get answer choice E. This is not related to hypertension either. Now you're left with ASD or pulmonary AV shunting. Which one of these two things would you find in this patient? An ASD, right? What does an ASD do? So let's look at it. Remember, that's your ASD is part of the vape later mnemonic. It causes later cyanosis, and that we see right here. Right, ASD. So you can see how in an ASD you're going to have the possibility of a paradoxical emboli, right, where systemic venous emboli use ASD to bypass lungs and become systemic arterial emboli. Things are going from the right atrium into the left atrium instead of going to the right ventricle. Right, so things that were supposed to go from the right atrium into the lungs and cause a pulmonary emboli instead going to the left atrium, left ventricle, and aorta and either cause a stroke or a DVT, right, systemic emboli. That's not what our question is related to at all. None of those things explain this. So the only answer choice you're left with is a pulmonary AV shunting may be found. And this is a question about hereditary hemorrhagic telangiectasia, also known as Osler-Weaver-Rindu syndrome. an autosomal dominant disorder which has telangiectasias like this, recurrent epistaxis, which they told you about, right? Frequent nosebleeds since adolescence, AV malformations, which is our answer, GI bleeds, and hematuria, which is probably why he has the hypoxia. Okay, the right image is the Shamrock sign seen in cases of hypoxia. This is clubbing. So, Rindu is in cardiovascular pathology. It's the last thing they talk about, and that's what we're looking at, right? So this is another image you can get, something like this. And this is a URL question about the same thing too. A 23-year-old Caucasian male who knows recurrent severe nosebleeds is found to have a pink spider-like lesion on his oral and nasal mucosa, face, and arms. He most likely suffers from what? Rindu. Mucosal involvement can be anywhere from the lips to the respiratory to GI and urinary tracts. Rupture of these telangiectasias cause epistaxis, GI bleeding, and hematuria, which can present in many different ways on labs. That's it. 34. Excuse me. 34 was a question about heart failure. So this is a 68-year-old man, so he's very old. Comes to the physician because of a 10-month history of shortness of breath, swelling of his feet. He has a family history of cardiovascular disease. He smoked 2 packs of cigarettes daily for 50 years. Pulse is 80, respiration is 24, blood pressure is 150/80. Physical exam shows 3+ pitting edema of the lower extremities. Diffuse scattered wheezes are heard bilaterally on auscultation of the chest. Cardiac exam shows a grade 2/6 pan-systolic murmur heard best at the lower left sternal border, which increases on inspiration. Right, so systolic murmur that increases with inspiration. Okay, the point of maximal impulse is palpated in the subxiphoid line, so right here, and S1 and S2 are distant. Okay, abdominal examination shows a liver span of 14 centimeters. Which of the following is the most likely diagnosis? So everything that's happening to this patient practically spells out heart failure. Right, he has the edema and everything. Heart failure, things are backing up into his lungs, right? So scattered wheezes are heard. Like, don't get confused. There's really nothing confusing. They try to give you information in a very technical form. Don't let that intimidate you. So you look at all your answer choices, which of these is related to heart failure, and it's the cor pulmonale, right? This patient has obvious symptoms of heart failure, and cor pulmonale refers to isolated right heart failure due to pulmonary cause, where it is of right ventricular origin due to pulmonary artery hypertension. The patient has symptoms of right heart failure such as peripheral edema, hepatomegaly, and the JVD, right, where the murmur increases on inspiration. Right? Not only would the murmur increase with inspiration, the jugular venous dissension would also increase with inspiration because everything from the right heart is backing up. Okay? Aortic stenosis presents with the sad symptoms of syncope, angina, and dyspnea, and that has something called pulsus parvus et tardus, usually in a very old patient like ours, but again, that's not what we're seeing in our patient. He doesn't have those symptoms. Cardiac amyloidosis causes restrictive heart disease in very elderly patients. They didn't mention anything about amyloid. Coronary artery disease, as choice D, would have angina, and this patient did not have angina, right? Primary pulmonary hypertension, which was a bullshit answer choice to kind of really, confuse you and bait you into picking it. If you don't remember cor pulmonale, you would pick E. So E was the second most highly picked answer choice. Is a hereditary pulmonary artery hypertension and would have a second insult like infection or systemic sclerosis, leading to accentuation of P2. Okay, but his S1 and S2 sounds are both very distant, possibly because of the there being some kind of tamponade thing, possibly, right? Anything could happen. So that was basically it for this patient. Very interesting cardiology question, but not one that you should definitely be getting wrong. I can see people getting wrong. I can definitely see people picking E, but you have to remember the hereditary form, page 752. Also, usually only occurs in females. That's another thing, at least as far as step 1 is concerned. But it's going to be one that has a very poor prognosis, right? He's going to have crazy amounts of endothelium and low vasodilators. So you get progressive dyspnea, enlarged pulmonary vessels, history of systemic sclerosis, and these things often need a second insult, right? But that's not there. Okay, so like I put here, this is a note from URL, right? There will be an accentuation of the P2 usually requires a second insult, like a disease process involving endothelial prostacyclins. So it's not happening. This guy's not related to this stuff at all. He just has heart failure. And cor pulmonale is discussed in cardiology, 334. So they tell you, where is it? Did I look at the wrong page? Page 334 discusses heart failure. What did I do? No, it doesn't. Probably wrote down the wrong page. This page right here, page 328. Okay, let me fix that. So if you look at heart failure, something you should definitely be studying really hard when you do cardiology. This is the UWorld breakdown of the pathogenesis of CHF. This is a full explanation of that, right? And then here you can see right heart failure most often results from left heart failure. Cor pulmonale refers to isolated right heart failure due to pulmonary cause like pulmonary hypertension. That's what our guy had, right? They gave you a lot of pulmonary information in that question too. 35. A 35-year-old woman comes to the physician because of pain of her left leg for 2 days. Physical exam shows a DVT in the lower left extremity. Lab studies show a platelet count of 200,000, prothrombin time of 12 seconds, and PTT of 37. So everything's pretty much normal. Treatment of heparin is started 5 days later. Physical exam shows no active bleeding. Her platelet count now is 120K. Which of the following best explains the decreased platelet count? So you know immediately heparin and then the platelet count went down. That's HIT, heparin-induced thrombocytopenia. You look at your answer choices, and the only one, they worded it weirdly, but it's D, drug-related antibodies, which is HIT, right? This patient had a DVT for some reason, but most of her labs are perfectly fine. After starting heparin, her platelet count went down, which is exactly how HIT is defined. She developed antibodies against platelet factor 4. Okay, so what are these other answer choices? Well, let's look at HIT first, 469. So right here, you can see this image. This is how HIT works, right? So you have a platelet, it has PF4, it has the FC receptor. You take heparin, heparin ends up binding with PF4, and this thing is something that your body doesn't recognize, so you make antibodies. You get immune complexes against it, right? And then you end up having platelets being removed by the spleen, as well as platelet activation causing more platelet aggregation. Ultimately, you run out of all your platelets, so you get thrombocytopenia and thrombosis. Really bad. You never give that patient heparin again, and now you would start giving that patient low molecular weight heparins, right? Or direct thrombin inhibitors if necessary. So these other answer choices, antithrombin 3 deficiency. Antithrombin 3 deficiency shows an increase in PTT after heparin administration. That's what you're going to see. We didn't see that, right? After giving heparin, had her PTT gone up, that would be a sign of antithrombin 3 deficiency, because heparin actually enhances antithrombin 3 activity. So antithrombin 3 deficient patients will need higher doses of heparin for anticoagulation. Antithrombin 3 usually inhibits factors 2, 7, 9, 11, and 12. The other answer choice here that was weird was E, Kasabach-Merritt syndrome. What is that? That's actually hemangioma with thrombocytopenia, and it's a rare disease, usually of infants, in which a vascular tumor leads to decreased platelet counts. Okay, we didn't have that either. It's also known as hemangioma thrombocytopenia syndrome, so just remember that in case it shows up on your next NBME or something. The other answer choices, you should know what they are. Cold agglutinins are related to like mycoplasma or antibodies to your red blood cells. DIC is DIC, right? After pregnancy complications or sepsis, anything like that. Migratory thrombophlebitis is a sign of visceral cancer, usually stomach cancer. And that's about it. Okay. 36, a 58-year-old man comes to the physician to obtain a prescription for benzodiazepine because he's experiencing an intolerable situation at work. He says that he needs to work until the age of 60 years before he can retire, but his younger boss is expecting too much of him. He feels anxious and thinks that he can complete his last 2 years of work if he decreases his anxiety. The physician prescribes a 1-month regimen of benzodiazepine therapy and schedules a follow-up appointment. 2 weeks later, a very interesting question, some weird shit happens. The patient's wife calls and says, "My husband just got fired. I know it's because he was taking too much of that drug you gave him. Didn't you know that he has a long history of alcoholism?" Which of the following is the most appropriate initial action by the physician? So you just gave some 58-year-old guy benzodiazepines because he needed it for his anxiety, apparently. But in all reality, he only requested it because he's an alcoholic. So now he's fired. So what do? The only answer choice that made sense was the first one. Contact the patient to discuss the situation. Your obligation is only to your patient, no one else. You don't talk to anyone else about your patient whatsoever, etc., etc. You call the patient, you be like, yo, what the fuck, dude? I didn't know you were alcoholic. Like, what's wrong with you? And that's not what you would really say. B, the other answer choices don't make any sense. B says, contact the risk management department. That's not happening. Discharge the patient from medical practice for inappropriate use of medication. That's not what you do. Even when someone is actually abusing opioids, they're known for trying to seek opioids from multiple locations. You put them on a list so that if they ever go try to get opioids anywhere, they'll never get it. No one's going to give it to them. You don't discharge the patient from medical practice. That's not a real thing. Inform the patient's wife. You can stop reading the rest of that right there because you don't do anything with the wife. It has nothing to do with her, right? Refer the patient to a substance abuse program. That would be something you would do after contacting the patient to discuss the situation. Okay? You would talk to him like, hey man, are you actually an alcoholic? Do you have issues drinking? Do you want me to help you get over your alcohol addiction? Right? That would be the second thing, not the first. So E was just a beta of an answer choice that you would definitely be inclined to pick if you're tired and you're thinking in that way, if that's what you're leaning towards. So how you think when you read questions like this really can affect you, because you could be following the wrong map and you would pick the wrong answer choice, but it's definitely, I can see someone picking E as an answer choice too. 37, a 21-year-old woman comes to a physician because of a 10-day history of difficulty walking. 2 years ago, she had loss of vision in the left eye, which improved over 2 months. Neurologic exam shows decreased visual acuity in the left eye with pallor of the optic disc. All of this is looking just like multiple sclerosis already. Very young woman with some kind of waxing and waning blindness. She has a broad-based gait. MRI of the brain shows lesions in the white matter in the cerebellum, multiple sclerosis. Which of the following best describes pathogenesis of the disease process in this patient? So the pathogenesis is involving antibodies. So you look at your answer choices. A was an excellent bait of an answer choice. Very baitful. Antibodies with specificity for axonal microtubules that bind axons. And you see antibodies and you see axons which you relate to the brain, you just pick it. But that's the wrong answer choice. This is not what our patient has. B, CD4 positive T lymphocytes against myelin basic protein. This mentions myelin. You should be very inclined to pick B. If you're thinking multiple sclerosis, you should be very inclined to pick B. Even if you're confused about whether it's CD4 positive T cells. C says CD8 positive T cells against astrocytes, but it's not involving astrocytes, so C is wrong. Complexes of rheumatoid factor and IgG, irrelevant to our patient. Inflammatory vasculitis of perforating arterioles, irrelevant to our patient. This patient has antibodies against myelin basic protein. This type 4 hypersensitivity involves Th1 and Th17 helper T cells, and the actions are via CD4 positive T lymphocytes. Remember that CD8 positive T cells are involved in killing viruses, which is not what this question is about. Right? And choice A is actually talking about antibodies to tau protein. Tau protein are the axonal microtubules that they're mentioning here. And this is something you would see, not antibodies, but the axonal microtubules are what you would see in pig bodies, right? In pig disease. Those are the pig bodies. Those are the tau proteins that become all jumbled up together. And you can find really good videos and images online of how tau bodies or tau proteins kind of separate from the entire microtubule in frontotemporal dementia. So that's not what our patient had, right? So this is just multiple sclerosis, page 567. They don't mention myelin basic protein in first aid itself, but I have it here from UWorld, right? Myelin basic protein, Th1 helper T cells reacting to myelin basic protein. Right? I don't think they mention it here. I don't remember. Yeah, they don't really mention myelin basic protein. But they do mention other things that they don't have a picture for, like this thing right here, right? Oligoclonal bands, right? IgG uniform band is normal, but if you have IgG oligoclonal bands, that's pretty much diagnostic of multiple sclerosis. These bands up here, Right? It's supposed to be nice and diffused, nothing. But here you can see multiple distinct bands. So multiple sclerosis has a lot of pathophysiology to it. You want to make sure you know all of it because NBME loves having questions on multiple sclerosis. Okay, 38. I'm just going to go up to 40 for this video. So 38, a 27-year-old pregnant woman at 18 weeks gestation comes to the physician for a routine prenatal exam. The uterus is consistent in size with an 18-week gestation. Ultrasonography shows a male fetus, the collecting system and pelvis of the left kidney is dilated, and the renal cortex appears compressed. The left and right ureters are not dilated. The right kidney appears normal. Amniotic fluid volume is also normal. Which of the following is the most likely cause of the renal findings in this patient's fetus? So they gave you a lot of anatomical description of what's happening, and they want to know what's wrong with the fetus. So you look at all your answer choices, you try to figure it out. And you knock out whatever you can knock out. So, abnormal ureteral insertion into the bladder wall. So this is the thing where your ureter is supposed to enter the bladder at a very nice angle. If it enters at like a 90-degree angle, urine might back up. But that would cause dilation of the ureters, and they tell you this fetus's ureters are perfectly fine, so you knock out A. Agenesis of the upper urinary tract. But they didn't describe that the upper urinary tract is missing, so I wasn't inclined on picking that at all. Congenital urethral stricture. A urethral stricture. So if the urethra has a stricture. Well, if the urethra has a stricture, right, ultrasonography shows that the pelvis of the left kidney is dilated and the renal cortex appears compressed. This compression thing was weird. Left and right ureters are not dilated. Right kidney appears normal. So it only occurred on one side, which is another weird thing. But urethral stricture is like, congenital. You could think about it. You could leave that there. Keep going. An ectopic ureter. So an ectopic ureter is usually part of that other renal pathology where you might have two ureters or something. But they didn't mention anything like that. They just said he has normal ureters. Or non-dilated ureters. So I am not inclined to pick that. Incomplete recanalization of the proximal ureter. And then F, posterior urethral valves. If you have posterior urethral valves, or if you have a urethral stricture even actually, your ureters will probably be dilated. Right? Your ureters would not look normal. So if we look at all of that in our path section of renal, you can see the various images I have right here, right? So you see posterior urethral valves, right? Your ureters are dilated because the valves in the urethra down here is backwards. Okay, so everything is just backing up. So even the bladder is extremely full and all the urine is just everywhere, right? So that's really bad. Here you can see the duplex kidney, which is pretty much this one up here, the upper one, that's pretty much an ectopic ureter. But actually the lower one here, that's the ectopic ureter. And that's not what they're talking about in our patient at all. If you had what else could you have? You could have the incorrect angle of entrance, right? So this angle that it's supposed to come in at is very significant because it allows urine to flow down. If the angle is not good enough, it could back up, but then the ureter would be dilated. So that's not what's happening to our patient. There's one thing here. It says unilateral renal agenesis, right? Ureteric bud fails to develop and induce differentiation of the metanephric mesenchyme. Complete absence of kidney and ureter. Again, that's not happening to our patient either. None of these things really fit our patient's scenario. Right, so it turns out that what they're talking about is actually E, which is what I just picked because I knocked out everything else and I was like, maybe it's this shit. I've never really heard of recanalization of the proximal ureter, but it was the only place where I can imagine the ureters must not be dilated, so I picked it. Right, this patient has proximal ureteral atresia. Never heard of it, no idea what it is. You can find pictures on Google about it, but it's probably extremely rare. They're just asking a question about it. And the way you answer these questions is really based off of the anatomical image they're drawing out for you. Draw it out in your mind and understand that that anatomical picture will only fit your correct answer. So the other answer choices must have a different anatomical picture. 39. A 33-year-old man comes to the physician for a follow-up exam. He was diagnosed with epilepsy at the age of 10. His most recent seizure, which was generalized tonic-clonic, was 5 years ago. At that time, his medication was adjusted. He has no other history of major medical illness and has not had any collisions while driving his personal motor vehicle. Current medications include carbamazepine. His vital signs are within normal limits. Physical exam shows no abnormalities. Which of the following best describes this patient's status with respect to driving? Okay, this was a very interesting question that also goes to show the example I just told you guys earlier, that the mental map that you take on how you're going to approach a question can really heavily influence the answer choice you pick, and you could pick the wrong one. This guy has epilepsy. It's been 5 years since he had any kind of crazy epileptic episode, so it seems like he's being managed fine. Now, this might be the wrong map you're taking. It seems like he's fine, but you never know when he might have another seizure. So we should probably not let him drive. And then you would go ahead and pick answer choice D. He is not medically qualified to drive while he takes carbamazepine, while he's treating himself. That would be the wrong thing to do. Be realistic, right? Anyone can have a car accident. You can't take the privilege of driving away from someone simply because they might have some kind of incident. A person driving, anyone, me, you, anyone driving might suddenly die. Does that mean you could take away their privilege to drive? No, right? You can die while driving. It's something that's really rare now that I think about it. But you can have any kind of issue while driving, and should I take away the privilege of driving from you just because you might have a certain issue while driving? No, definitely not. And that's where this kind of falls into place, right? So here, the best answer to pick was just B. He is medically qualified to drive because he's taking medications to take care of himself, and he has never had an accident, so he's already better than many other drivers out there. And then, he hasn't had any epileptic episodes in the last 5 years, at least from what he's telling you, right? Maybe he's had episodes, but you have to take his word for it. Regardless, you cannot take away his privilege to drive. He's not a criminal. He's not messing up in any way. Otherwise, anyone driving, even non-epileptic people driving, can have accidents, can have issues, anything can happen. We can't take away his right to drive, right? And that's why I went with B. But I could totally see another student I was working with was very much inclined to say that there's no way this patient should be driving. Now, they did a good job. They didn't put a clear answer like he's not medically qualified to drive. They added more to the sentence, which kind of made the answer choice bad, right? Like, look at C. Even if you firmly believe he's not medically qualified to drive, if they had an answer choice like B, where it just said he is not medically qualified to drive, that would make this question so much harder now. But here, C says he's not medically qualified to drive until 10 years have passed. That sounds stupid. Why would we, 10 years? Like, what does that mean? And then D, he is not medically qualified to drive while he takes carbamazepine. Again, why would he not be allowed to drive while he's actually treating himself? He should not be medically qualified to drive if he's not taking medications, right? If he's not treating his epilepsy. That might be a whole different scenario. So those two answer choices really didn't even make sense. And A, determination of his driving status should be deferred until he has undergone an EEG while awake and asleep. Well, an EEG is just going to tell you he has epilepsy, but it's not going to tell you whether or not he can drive. So doing an EEG would be unnecessary. It's just going to be pointless. Your EEG, even on carbamazepine, will still tell you this is an epileptic patient. He's not going to have seizures on the EEG, but you're going to see some abnormalities there. So the other answer choices just didn't make sense. Last question for this video, number 40. 52-year-old woman with breast cancer comes to the physician for a follow-up exam. She had a 4-week course of radiation treatment 6 months ago. Her respirations are 26 per minute. Physical exam shows no recurrence of the cancer. A CT scan of the chest shows bilateral patches of atelectasis in the upper lung fields. The atelectasis in this patient most likely developed because of which of the following primary pathophysiologic processes? So she just had a lot of radiation, right? They tell you that. It's a 4-week course of radiation to treat her breast cancer, which is right over your lungs, right? So now, what did that radiation cause? Well, the radiation must have caused fibrosis. None of those answer choices are fibrosis. But you can knock out answer choices. Radiation does not cause compression. Pressure causes compression. Like a deep diver might have compression of the lungs, right? Because pressure under sea is much higher. So A is wrong. Consolidation will be like a pneumonia thing. That's wrong. So you knock out B. Obstruction would also be something like inhaling something, swallowing something incorrectly into your trachea, blah, blah. This is not obstruction. And resorption just doesn't make any sense. What are you resorbing? So it must have been contraction. And you know when things fibrose, they kind of contract. That's what caused the atelectasis in this woman. Done. And don't ever think too hard. These questions are not that bad. I got 41 wrong too. And that's the 4th question, I think, that I got wrong within the first 50 so far. But I'll stop here for now. We made it to an hour and a half. And then tomorrow at noon, I'll continue from 40, go on to 40 to 60 maybe. Alright, so thank you very much for joining. Keep studying, and then I'll see you guys tomorrow.